Antihypertensives are used to reduce blood pressure. We are going to take each subclass of antihypertensives individually and look into their mechanisms of action, examples, side effects, and contraindications. ACE inhibitors, angiotensin-converting enzyme inhibitors, and ARBs, angiotensin receptor blockers. Before we talk about ACE inhibitors and angiotensin receptor blockers, it's important to understand the renin-angiotensin-aldosterone system, which controls long-term blood pressure. Firstly, the liver produces angiotensinogen, which is released into the bloodstream. When blood pressure is low, this is detected by the kidneys, which stimulates the release of renin from the juxtaglomerular apparatus, so the RAAS is activated. Renin converts angiotensinogen into angiotensin 1. Principally in the capillaries of the lungs is an enzyme named ACE. ACE converts angiotensin 1 into angiotensin 2. Angiotensin 2 then binds to angiotensin 2 receptors on target cells, resulting in several different effects. It leads to an increase in sympathetic activity, vasoconstriction of arterioles, ADH secretion from the posterior pituitary resulting in water reabsorption in the collecting duct. Angiotensin 2 also acts on the proximal convoluted tubule of the kidney to stimulate sodium and fluid retention and potassium excretion. Aldosterone released from the adrenal cortex further contributes to sodium and fluid retention and potassium excretion, overall resulting in an increase in blood pressure. ACE inhibitors block ACE, which reduces angiotensin 2's blood pressure raising effects. Normally ACE breaks down bradykinin into inactive components, therefore ACE inhibitors increase bradykinin levels. Bradykinin increases the production of nitric oxide and prostacyclin, which are both vasodilators. Examples of ACE inhibitors include ramipril and captopril. They all end in pril. Side effects of ACE inhibitors include a dry cough due to the accumulation of bradykinin, hyperkalemia, as the reduction in angiotensin 2 leads to reduced potassium excretion in the kidney, as well as fatigue, dizziness, and headaches. The contraindications of ACE inhibitors include renal artery stenosis, pregnancy, hyperkalemia, and a chronic cough. Angiotensin receptor blockers block the angiotensin 2 receptor to prevent angiotensin 2 blood pressure raising effects. They tend to be used when the side effects of ACE inhibitors cannot be tolerated, and examples include candesartan and losartan, and they all end in sartan. Side effects of angiotensin receptor blockers include headache, dizziness, back pain, hyperkalemia, and fatigue. And the contraindications are very similar to those of ACE inhibitors, which include renal artery stenosis and pregnancy. The next subclass of antihypertensives that we're going to discuss are called the calcium channel blockers. Before we talk about calcium channel blockers, we need to understand the role of calcium in the blood vessels and the heart. In the blood vessels, there is the endothelium, which is the innermost layer of the blood vessel wall. It forms an interface between the blood in the lumen and the rest of the blood vessel. Then surrounding the endothelium is the vascular smooth muscle cells. L-type calcium channels are present in the vascular smooth muscle cells, and calcium entry through this channel results in vascular smooth muscle contraction. Subsequently, there is vasoconstriction of blood vessels, therefore resulting in an increase in blood pressure. Calcium is also extremely important in the heart. In the heart, there are the pacemaker cells, which control the rate of the heart, and the cardiomyocytes, which control the contractility of the heart. There are L-type calcium channels on both the pacemaker cells and the cardiomyocytes. Calcium influx in the pacemaker cells results in increased pacemaker discharge, increased heart rate, and increased blood pressure. Calcium influx in the cardiomyocytes results in increased cardiac contractility, increased cardiac output, and increased blood pressure. There are two classes of calcium channel blockers, dihydropyridines and non-dihydropyridines. Dihydropyridines mainly act on vascular smooth muscle. They block the L-type calcium channel to reduce smooth muscle contraction. Subsequently, this results in vasodilation and a reduced blood pressure. Examples of dihydropyridines include amlodipine and nifedipine. They always end in dipine. Side effects are due to systemic vasodilation, resulting in dizziness, flushing, headaches, and peripheral edema. Non-dihydropyridines mainly act on the heart. They block the L-type calcium channels in the pacemaker cells and the cardiomyocytes. This leads to a reduction in heart rate and cardiac output, overall resulting in a decrease in blood pressure. Non-dihydropyridines can be used to treat hypertension, but they are primarily used as antiarrhythmic drugs and in the treatment for angina. Examples include diltiazem and verapamil. Side effects are as a result of myocardial depression, resulting in bradyarrhythmias and atrioventricular block. A good way of remembering the difference is that verapamil mainly acts on the ventricles, which is V and V, and amlodipine mainly acts on the arteries, which is A and A. Contraindications of calcium channel blockers include congestive heart failure. This is because in heart failure, the strength of contraction is reduced, therefore using calcium channel blockers will reduce this even further, causing more problems. Other contraindications include cardiac outflow obstruction and cardiac conduction disorders. Another subclass of antihypertensives are diuretics. Diuretics work on the functional unit of the kidneys called the nephron. We have millions of nephrons in the kidney and there are different parts. The Bowman's capsule is the first part and it forms the first step in the filtration of blood from the glomerulus, which is a network of capillaries. There is then the proximal convoluted tubule, descending loop of Henle, ascending loop of Henle, distal convoluted tubule, and finally the collecting duct. Surrounding the nephrons are blood vessels, but for the purpose of this drawing, we will just draw a blood vessel going through the middle. The blood vessels allow for the secretion and reabsorption of substances between the blood vessels and nephron. There are three different types of diuretics, including loop diuretics, thiazide diuretics, and potassium-sparing diuretics. Nevertheless, they all have the same overall function, which is to increase urine output, reduce fluid overload, leading to a reduction in blood pressure. We're only going to focus on thiazide-like diuretics and potassium-sparing diuretics, as these are the only diuretics mentioned in NICE guidelines for use in hypertension. Thiazide diuretics include chlorothiazide and chlorphalidone. Unfortunately, there isn't a pattern in terms of their names. They work on a sodium chloride transporter in the distal convoluted tubule. In normal conditions, the transporter reabsorbs sodium and chloride back into the blood, therefore water follows, leading to an increase in blood pressure. Thiazide diuretics inhibit this transporter to prevent iron reabsorption and subsequently water reabsorption to reduce blood pressure. There is a transporter in the collecting duct which reabsorbs sodium but secretes potassium and hydrogen ions. Aldosterone binds to its receptor, stimulating the reabsorption of sodium and water and potassium and hydrogen ion excretion via this transporter. Potassium-sparing diuretics inhibit this transporter directly or act as aldosterone receptor antagonists. A direct inhibitor is trimethorine and an aldosterone receptor antagonist is spironolactone. Either way, they both reduce sodium reabsorption and therefore water reabsorption, so blood pressure decreases. It also inhibits potassium secretion, so potassium is spared, suggesting why they are called potassium-sparing diuretics. Side effects of thiazide diuretics include hyponatremia and hypokalemia due to the loss of these ions, hypovolemia due to the loss of fluid volume, hyperuricemia, metabolic alkalosis, and hyperglycemia. Side effects of potassium-sparing diuretics include hyperkalemia due to the retention of potassium, metabolic acidosis due to the retention of hydrogen ions, and gynecomastia, specifically for aldosterone antagonists. The next subclass of antihypertensives that we're going to talk about are the alpha-1 blockers. As mentioned previously, in blood vessels there is the endothelium, the lumen, and then surrounding this is the vascular smooth muscle cells. We're going to take a closer look at a singular vascular smooth muscle cell. On the membrane of vascular smooth muscle cells, there are alpha-1 receptors. Increased sympathetic activity causes adrenergic nerve endings to release epinephrine and norepinephrine, also known as adrenaline and noradrenaline. Epinephrine and norepinephrine then bind to alpha-1 receptors on the vascular smooth muscle cells. This results in contraction of the smooth muscle and blood vessel constriction, subsequently leading to an increased blood pressure. Alpha-1 receptor blockers, for example doxazosin, block the alpha-1 receptor, which inhibits the adrenergic activity and causes vasodilation, subsequently leading to a reduction in blood pressure. Side effects of alpha-1 receptor blockers include dizziness, lightheadedness, and fainting, so it is recommended that they are taken before bed. Contraindications include postural hypertension and micturition syncope. We're now going to talk about beta blockers, which are similar to alpha blockers. Like alpha-1 receptors, beta receptors are also involved in the sympathetic activity. Beta-1 receptors can be found in the heart. They are found on the pacemaker cells of the heart, as well as on the cardiomyocytes. Increased sympathetic activity will increase the release of norepinephrine and epinephrine from adrenergic nerve terminals, which will bind to the beta-1 receptors. In the pacemaker cells, this will increase the heart rate and subsequently increase the blood pressure. In the cardiomyocytes, it will increase the force of contraction, subsequently increasing cardiac output and therefore increasing blood pressure. Beta blockers can be selective, for example, atenolol and metoprolol. They are selective as they solely inhibit the beta-1 receptors in the heart, therefore the beta-1 receptors in the pacemaker cells and cardiomyocytes. This will reduce the heart rate and reduce the cardiac output, subsequently reducing the blood pressure. Beta blockers can also be non-selective, for example, propranolol. They also inhibit the beta-1 receptors in the pacemaker cells and cardiomyocytes as seen before with the selective beta-1 receptor blockers. However, they also inhibit other beta receptors which we will not talk about today. As you may have already gathered, the names of beta blockers always end in olol. Side effects of beta blockers include bradycardia, bronchoconstriction, fatigue, and sexual dysfunction. Contraindications include obstructive lung disease, second or third degree heart block, diabetes, and peripheral vascular disease. Thank you for watching. We have now covered each subclass of antihypertensives. I hope you have gained an understanding into the pharmacology of the antihypertensives. You can now return to the workbook and continue with the relevant activities.